Hello. Thank you very much for asking me to speak at the Cauda Equina Syndrome charity event. I have been asked to give some observations from my practice as a lawyer, which I hope you will find interesting. I understand you make up an audience of patients, clinicians and possibly lawyers as well. So a wide audience. I hope that in this next half hour or so, I can give you some insights into why cases end up on across my threshold at least, and perhaps give some food for thought. So who am I? My name is Sally Hatfield. I'm a barrister in private practice in Manchester. I've been a barrister for about 30 years, and for about 20 years I have specialised in clinical negligence cases, predominantly on behalf of claimants. I became a QC in 2013, and since then my practice has focused on the very complex and grave, not to say catastrophic, personal injury situation. And very sadly, Cauda Equina cases fall squarely within that categorization. They are complex, grave, and very sad. Why do I say sad? Well, all personal injury work is obviously sad and grave, but the particular feature of Cauda Equina syndrome is the interference with the management of basic bodily functions. At a stroke, one loses the ability to pass urine normally. One loses the ability to, one can lose the ability to have easy control of one's bowels, and one loses all perineal sensation, and so sex life is completely gone. And for my clients to find that you can lose those things as a consequence of a back condition, and to lose them permanently is shocking for them, bewildering and perplexing to them, and to discover that it's completely permanent is appalling for them. And more than one client has told me that they would rather put up with the pain than to have lost the ability to have an enjoyable sex life with their partners. It's absolutely awful for them. But it's not a loss. It's not that is well recognised in the English legal system. If you lose the ability to control your bladder or your bowels, you can still go to work. You can still bring up your family. It's very painful and time consuming, and it's an awful thing to have to do, but you don't lose out financially. Without a sex life, you can continue similarly to work, to function independently. You've not lost out financially, and there's nothing that money can buy to help. But the legal system doesn't focus on that. You can and you will be awarded a token sum called general damages if you succeed in your claim. General damages is an award for the injury itself, and it can and it will allow something for the loss of those intimate things, but only in a very token way and in a pretty poor way, in my experience. It doesn't allow a huge amount of money. What the remainder of the damages in a clinical negligence case that succeeds will relate to are financial losses. For example, if because of your pain you cannot work, then you can bring a loss of earnings claim, and your loss of earnings will be compensated. If you cannot safely go upstairs because profound weakness or foot drop, you can claim towards the cost of level access accommodation. Oh, forgive me, my button has stopped working. If you need physiotherapy because of the weakness or the foot drop, for example, you can seek private provision. If you can't, for example, stand up in the kitchen to prepare meals, then we can claim damages for you for a perching stool. For all those things, something can be bought to help, and damages will follow. But for the bladder and the bowels and the perineum, it's very different. For an insensate perineum, what can we buy to help? Well, sadly, nothing. One can put in a bit of sexual counselling, but that's in my experience, merely to adjust. It can't actually help. Nothing will bring that back. We can't buy anything or help you buy anything to help. It's terrible. It's a permanent loss for which nothing can be bought. For bladder dysfunction, if you need Peristeen, forgive me, intermittent self-catheterization, yes, in theory, you can bring a claim for the private costs of intermittent self-catheterization, for the private cost of buying the catheters. But in my experience, the NHS legal team can show that the provision of catheters is efficient and comprehensive and pretty stress-free on the NHS, and they can argue that the patient, the claimant, is pretty unlikely to do that. To use intermittent private provision. And if they can do that, then you're not going to claim the damages for them. Similarly, for Peristeen, irrigation for bowel management, again, NHS provision is good in my experience, and it can be difficult for a patient to prove that they will actually buy those kind of things privately, and therefore the defendant will successfully say, well, we don't need to pay you damages for it. So they are losses that are very profoundly undercompensated because the compensation system is geared up to bind things that can help, and sadly nothing can help. And remember as well, though, that even if in a successful claim where you do succeed in obtaining significant sums, and they are significant sums for accommodation or electric wheelchairs or whatever, the claimant is still going to be affected lifelong by chronic pain. It's not going to get better. There's no cure for the perineal numbness. There's no cure for the bladder and the bowel dysfunction. It goes on forever. And the litigation process itself is not a walk in the park. It will take many years. It's a punishing process. There is no guarantee at the start that you'll have anything at the end. It's a difficult process. So prevention is very obviously preferable to litigation. And looking at prevention and why it might be missed, let's just look at this, a few observations. It is obviously a rare condition, and clinicians shouldn't go around thinking it's going to be coming through the door every day, but no clinician should be unaware of it. There's no excuse for a clinician not knowing anything about it, but it is still being missed. A national audit in 2017 found out that well-publicized standards are simply not being met. And the Getting It Right First Time programme specialty report on spinal services in 2019 found that it represented almost a quarter of spinal surgery litigation claims. It's just being missed and being missed, despite those well-publicized standards. Let's just have a look at those. So the British Association for Spinal Surgeons has for many years, since about 2015, I think, had guidelines in place that are very simple, telling spinal surgeons all about Cauda Equina Syndrome and what they should do. They joined forces with the Society of British Neurological Surgeons, and in 2018 they produced these joint guidelines that are readily available on the internet, and they're very simple and very clear. And in the next 3 slides, I've just extracted some of 2 or 3 of the things that they say. So let's read them. They say this: Cauda Equina Syndrome is a relatively rare but disabling condition which can result in motor and sensory deficits, incontinence of urine and feces, and loss of sexual function. Any patient with a possible diagnosis of threatened or partial or complete Cauda Equina Syndrome requires urgent investigation. They go on. The reliability of clinical diagnosis of threatened or actual Cauda Equina Syndrome is low, and there should be a low threshold for investigation with an emergency MRI scan at the request of the examining clinician, and MRI must be available at the referring hospital 24/7. The decision to perform an MRI does not require discussion with the local spinal services. The MRI must be undertaken as an emergency in the patient's local hospital, and a diagnosis achieved prior to any discussion with the spinal services. The MRI must take precedence over routine cases, and any reasons for a delay or a decision not to perform an emergency scan should be clearly documented. if cauda equina compression is confirmed on MRI, there should be an immediate referral to an appropriate surgical service, and nothing is to be gained by delaying surgery and should be undertaken at the earliest opportunity, considering the duration and clinical course of symptoms and signs and the potential for increased morbidity while operating in the night. It's certainly true that it can be preferable to wait until 8 o'clock in the morning rather than doing it at 3 a.m. But 8 o'clock in the morning is the time you start, not middle of the day, later on in the day, because the guidelines go on. We don't consider there's anything in the literature that justifies contravention of this principle, and the reasons for any delay in surgery should be clearly documented. So it couldn't really be clearer, could it? But why is it missed? So I'm going to spend the next few slides looking at themes from my practice as to why it tends to be missed. So the first theme from a lot of my cases is this: the insistence on signs as well as symptoms. Frequently, the first thing that the patient will have are the subjective symptoms. It feels a bit different when they're passing urine. But what a lot of my cases have involved is the clinicians insisting on there being objective signs as well, particularly the anal sphincter test, which is believed in the cases I've done to be the true hallmark of a Cauda Equina syndrome, and that the symptoms can be the symptoms of the things that the patient complains of are of lesser importance. So let's look at this. This is a typical presentation from one of my cases in the accident and emergency department. And I think I've set it out in full because I think it shows the complexity of these cases. They're certainly not easy for clinicians, because often the presentation can be confusing, but let's look at what's said. So we have here history of long-standing back pain, twisted low back a week ago, and now developed pain radiating to the posterior aspect of the left leg and the posterior aspect of the right thigh. So we have bilateral leg involvement. History of numbness on the posterior aspect of both thighs. So some sensory abnormalities, but no history of incontinence of urine or feces. There is a history of difficulty in initiating micturition, so that's something the patient is complaining of. On examination, there's muscle spasm, straight leg raising 45 on both sides, some weakness of power and dorsiflexion and extension in the left and right, some limited sensation on the outer aspect of the legs, reflex one reflex abnormality, perineal sensation reduced, and here's the crux: anal sphincter tone normal. Plan, X-ray, L5, admit for bed rest and analgesic. So this patient wasn't sent home, but the MRI query, only a query MRI, and money tomorrow. Not now, not straight away, but possibly one tomorrow. Because the signs, the anal sphincter tone normal, was thought there to probably trump the symptoms, the complaint of limited sensation. So let's look at this in a tabular form. This is a typical presentation, in my experience, to a GP or to accident and emergency department. In the context of back pain and sciatica, the patient will complain of saddle sensory dysfunction or sensory loss or urinary dysfunction. They are then referred to a spinal team because the GP or the A&E team are worried about the possibility of Cauda Equina syndrome. Spinal team come along, they do the anal sphincter test, the patient's discharged. And unfortunately, by the time they come back, irreversible damage has been done. It's too late. But however quickly you operate, once everything's gone, you can't get it back. So here is the insistence on the signs being abnormal sufficient? Is a manual anal sphincter test, is it reliable? Well, I'm repeatedly told by experts in spinal and neurosurgery that no, it's not. It's a very difficult test to do properly, and it's quite a difficult test to interpret. And so it's only superficially an objective, clear indicator. And it really is much less reliable, that I'm told, than a patient saying to you, it feels different when I wipe. And the patient who says that to you is one that you need to think about very carefully. and a lot of these cases fall upon this problem where there's been a focus on signs rather than symptoms, and they can miss the insidious or early onset of Cauda Equina syndrome. And that's the time when you intervene, you can actually change the outcome. And remember what the guidelines say: a patient presenting with back pain and or sciatic pain with any disturbance of their bladder or bowel function and or saddle or genital sensory disturbance or bilateral leg pain should be suspected of having a threatened or actual Cauda Equina syndrome. So it's the complaints of symptoms are as important, or can be as important, as the signs, and why on earth would you want to wait for more? A next theme that comes out in some of my cases is this: a belief that you actually need frank incontinence before you need to do anything. Here we have a extract from notes in the context of back pain and sciatica: advice to call 999 if becomes incontinent of urine. Or this is from a statement of case. In relation to urinary function, the defendant asked whether the claimant had been incontinent. The claimant replied that her problem appeared to be the reverse, that she didn't feel any urge to pass urine and had to strain to do so. But the focus is on incontinence rather than the abnormality of sensation and the abnormality of function, which is, and patients are then discharged because there isn't that frank incontinence. But by the time frank incontinence has been reached, the patient is likely to be in the final version of Cauda Equina syndrome with retention. And by this point, there's little prospect of an improvement with surgery. And so we need to remember that the first signs will often be subjective and much more subtle, and the SBNS and BAS exhort clinicians to act upon them and not wait for there to be frank incontinence. A third group of problems is the clinician who wants there to be a full house of red flags before they take action. So a couple of 2 or 3 case, studies. I think it's gone too far. Let's go back one. Let me go back. There we are. To slide. So some incontinence of urine and doesn't know when needs to pass feces, no saddle anesthesia, nil else red flags. Well, what else do you need? You've got, surely you have enough to show there is a problem here. Some incontinence of urine, doesn't know when needs to open her bowels. That is sufficiently worrying for the threshold of suspicion that the guidelines suggest you should be watching out for to take action. Or this one, low back pain that worsened over the last 2 weeks, also radiates down the right and left leg, and weakness, unable to bear weight. No bowel accidents, but has been constipated, and no urinary symptoms or saddle anesthesia. And this is the same patient. I should have put these two together. Good resting tone, but unable to squeeze, complaining of increased weakness in the left leg and some altered sensation in the left leg. States saddle sensation altered, but normal bladder and bowel function. So we have, again, some suggestion of altered saddle sensation, excuse me, some suggestion of bilateral symptoms, but not a full house of red flags. And the clinician that insists on there being a full house will miss Cauda Equina cases. Or look at this. This is a case. So the son surprised the patient yesterday by, I think he called out at her. She jerked her back, the claimant. She got much more severe lower back pain since when she had no sensation she needed to pass urine. And when she did go, she had no sensation that she was passing urine. On examination, she couldn't sit down due to pain. Her range of movement was reduced in all directions. Reflexes were slightly abnormal, reduced sensation, pinprick, but no saddle anesthesia. And her abdomen seemed to be fine. Her bladder wasn't palpable. Discussed, no need admission currently, presumably because no saddle anesthesia had been found. But goodness me, what else? What more do you need? So the clinician that insists on a full house of red flags will miss the Cauda Equina case, because it fails to recognize, that clinician is failing to recognize that this is a syndrome. there will be a variety of presentations at onset. I've had one case where the only presentation was bowel impairment as the red flag. And the clinicians need to recognize that it can be a progressive condition going from an imminent to retention. And the importance is getting the imminent ones right, because once a patient has reached CESR, substantial relief from decompression is unlikely, and successful litigation is also unlikely. And as the guidelines say, nothing is to be gained by delaying surgery, and it should be undertaken at the earliest opportunity. So those are the three broad themes I've noticed in my practice as to why it's missed. But is that it? I began to wonder in my practice whether there is more of a conceptual misunderstanding between clinicians and patients into the whole Cauda Equina concept. And this thought began to occur to me when I was in a case conference with my solicitor and my client and experts in neurosurgery and neurology. Experts in neurosurgery and in spinal surgery. And we were asking the client repeatedly when it was that they noticed that their bowel and bladder function had deteriorated. And eventually, and completely exasperated, the client cried out, "Why do you keep going on about my bladder function?" It was the pain that was unbearable. They just couldn't understand why we kept banging on about it. This is a similar story from a witness statement. I still can't recall whether I was going to the toilet and emptying my bladder normally. I was in agony. The toilet was upstairs and sitting on the toilet was excruciating. The doctor told me I had no anal tone. I myself had not noticed any numbness due to the dominance of the pain. So that's what it is for the patient, for the client. It's the pain. But look at it from a clinician's perspective. To a clinician, back pain and sciatica, even if severe, do tend to resolve with conservative management and with time. And surgery in those cases is unnecessary and moreover can be damaging. Cauda equina is the exception. If the nerves of the cauda equina are compressed, even for a relatively short time, they don't tend to recover. So those cases do need surgery. But what distinguishes one case from the other? Is it the pain? Well, no, it's not. It's not the pain at all. It's the other features. It's the bladder and the bowel dysfunction. It's the subtle sensory loss. It's the motor weakness in the legs. And that's what the clinician needs to investigate. But to the patient, it's the pain. It's the pain, it's the pain, it's the pain. That's what it is for them. It is likely to be completely overwhelming and to be dominating their mental space. The last thing they will probably be thinking about is whether their bowel or their bladder function is normal. They just won't have noticed, and they probably won't have been thinking about sex. It's the pain. They just want it fixed. And therefore, are they going to be in the best frame of mind to be thinking accurately about their bladder, their bowel, their saddle, and to describe it? They just want the pain fixed. Are they going to be able to give the full history? And my suspicion is that doctors don't always explain exactly why they're asking these questions. They don't get across to patients the radical difference between lower back pain and sciatica on the one hand, and Cauda Equina Syndrome on the other. And I wonder if taking the trouble to do so would yield a more accurate history from the patient. Excuse me. Not that it's easy to take history. I accept that these patients in such terrible pain will be a struggle to take history from. And I know as well that pain can inhibit the need to go to the toilet and can alter one's perceptions. I accept all that, and I'm not hiding away from how difficult it will be. But you do need to get the patient to think beyond the pain and about the issues of relevance to Cauda Equina Syndrome. And simply, as I was writing in the notes, bladder and bowels tick is just not good enough. That doesn't show that you've really got through and explored those issues properly. Similarly, query any problems passing urine. You're not going to extract the answer. The patient may well not have noticed whether they've had any problems passing urine. You're not going to get to the heart of the discriminating factors between back pain and Cauda Equina Syndrome if you just ask that. What you need is to provoke thought with an explanation of why, and something I would suggest like this. When did you last pass urine? Get the patient to think when it was. Were the start and the flow normal? What did it feel like? If you wiped, what was the sensation like? To really drill down into the detail of it. And in that way, one might get to the history. Remember though, the problems of repetition. This is a theme that does come out in my cases, where the patient manages to the triage nurse to tell them everything, and then either they're in too much pain or they simply assume that what they said to the triage nurse will carry over. I think to the patient, the notion that you must give your history to each clinician that you're in front of is one that can be hard to get across. And the problems of repetition, or assuming a patient assuming that you will know that you, the doctor, will know what the patient said to two clinicians before you, is not an assumption you should easily make. Think also about, well, hospitals should be thinking about whether there are good protocols for urgent MRI scanning. One of the reasons the Getting It Right First Time team found that a lot of Cauda Equina cases had been missed was simply because of a lack of protocols for urgent MRI scanning. But now we've got the guidelines, the SBNS and the BAS guidelines, which are so very clear. I think that ought to be a thing of the past, or one hopes. But I go back, I leave you with this slide because I do wonder whether the problems that I see are possibly mainly about communication. The doctor talking in squares, the patient talking in circles, and the aim of the clinician surely must be to try and make the patient understand the square and give the detail that they really need in order to differentiate between back pain and sciatica on the one hand and Cauda Equina Syndrome on the other, and thus one hopes avoid any more cases crossing my threshold, about which I will be very pleased. That's all I have to say on the topic. If anybody wants to email me some questions, you can find me on the internet through my chamber's website, please do. But I hope you have found it of some interest. Thank you very much indeed.